Hi everyone, my name is Daniela Lisa Panesanton, and today I will talk about immunotherapy in renal cell carcinoma and Ribavirin for chronic hepatitis E virus infection in transplant recipients. Contents: definition, application in medicine, pros and cons, ISO in Ecuador, and conclusion. First, I will talk about immunotherapy in renal cell carcinoma. Definition: renal cell carcinoma is the most prevalent malignancy between the kidney, and the incidence is increasing. That due to improved radiological evaluation, more than 50% of kidney cancer are found incidentally, despite the fact that these incidentalomas are usually confined to the kidney. About 50% of all patients diagnosed with kidney cancer will develop a systemic disease.
Sunitinib is a standard first-line treatment for kidney cancer, but it's becoming decreasingly used in the first line. For these intermediate and high-risk patients right now, it's probably not the standard of care. The standard of care at Columbia and at other places, actually especially academic places, is combination immunotherapy with anti-PD-1 and anti-CTLA-4. So whether you'd get the same result with modern immunotherapy or not is a very good question, actually. The other thing is I can tell you that there have been preclinical studies and now clinical studies suggesting that you should give immunotherapy before surgery. There was a recent paper in the New England Journal of Medicine from the Hopkins group showing that in lung cancer, giving immunotherapy before surgery is much more efficacious than giving it after surgery. We don't know whether that's the case in kidney cancer or not, but we do know that sunitinib in the adjuvant setting after surgery has generally not been helpful, actually. So the question is, if we gave immunotherapy before surgery and compared that to immunotherapy alone, what would be the readout? That is being tested to some degree in an ECOG trial at this point with nivolumab monotherapy. But it is an important question. Again, the two things are, if it was a different drug, if it was real immunotherapy, or if it was neoadjuvant treatment was applied, would yes, still have the same result.
Application in medicine: immunotherapy and RCC, spontaneous progression of metastasis after nephrectomy, less than 1%. Presence of immune cells, cytotoxic T cells in resected tumor. Identification of tumor-associated AG that cancer NGC.
I think when we look at the treatment for advanced renal cell carcinoma, it certainly has changed significantly. In past several years, renal cell carcinoma doesn't respond to traditional cytotoxic chemotherapy, and we had the advent of the first target therapies with the VEGF TKIs, over now, I guess, close to 15 years ago, that really showed an improvement in progression-free survival. And then for a while, that was the mainstay. And then, back in 2017, we saw the first data showing that immunotherapy has a role in the frontline treatment with the presentation of that for Nivo and Ipi showing improvement in overall survival in immune poor risk versus sunitinib. And then since then, we've had other VEGF IO combinations with both axitinib pembrolizumab and axitinib adalimumab approved by regulatory agencies, given, in the case of axi-pembro, improvement in overall survival and progression-free survival versus sunitinib in all patients in the kind of risk group, and with axitinib improvement in progression-free survival. And so, there's a wide variety of options to offer our patients now. With, I think, TKI monotherapy being used less and less, given this data, and both, Nivo, Ipi, Axi, Pembro really becoming a new standards of care, given the overall survival benefit of patients with renal cell carcinoma.
Pros and cons. Retrospective reviews have indicated that the survival rate of children and adolescents with CRC is approximately 50 to 60%. adult CRC and pediatric CRC have similar stage-to-stage outcomes, very good outcomes for stage 1 and 2 disease, less favorable outcomes for stage 3 disease, and poor prognosis for stage 4 disease.
So the things are clearly evolving for several years now, but especially since last ESMO, where we had the results of nivolumab versus everolimus randomized phase 3 study, which demonstrated that in patients who fail 1 or 2 VEGF-targeted therapy, there is a role for IO, immuno-oncology, and namely nivolumab. It is important because this is changing one of our standard of care, and since last year this has been implemented in all the guidelines. What is important at this ESMO is that we're starting to have more information on which will be the next step in terms of combining those agents, for instance.
Is applied in Ecuador. According to the latest report from the International Agency Search on Cancer, in 2012, Ecuador had an incidence of 403 cases, 229 men and 174 women, ranking 8th and 11th as cause of cancer.
Checkpoint inhibition, that is actually a form of immunotherapy. So that whole class of therapy, what it essentially does is ramps up your own immune system and releases the brakes that the tumor created to slow down your immune system from fighting your own cancer. It lets go of the brakes so that you can fight the cancer yourself. And when it works, it is actually astounding. It's really quite remarkable. It doesn't work for everybody, but when it works, it's really quite remarkable. Well, interestingly, checkpoint inhibition, again, this immunotherapy approach, that has exploded on the scene for bladder cancer as well. And that is rapidly changing the paradigm for the management of advanced bladder cancer. And so there's active trials ongoing right now trying to figure out exactly what space that therapy should fit in. Should it just be in metastatic disease, or does it have a role in locally advanced disease or even earlier stages? So that is probably the single biggest advance in the last couple of years, and it's just taking bladder cancer by storm.
Conclusion. Immunotherapy has changed the landscape of management of metastatic RCC, several ongoing trials, optimal treatment sequencing, need for biomarkers, and immunotherapy clearly have a significant survival benefit in a subset of patients. Now, I will talk about the other topic, that is Ribavirin for chronic hepatitis E virus infection in transplant recipients. Definition: hepatitis E is a liver disease caused by infection with a virus known as hepatitis E virus. The virus has as less 4 different types: genotype 1, 2, 3, and genotype 4. Genotype 1 and 2 has been found only in humans. Genotype 3 and 4 circulate in several animals without causing any disease and occasionally infect humans.
So now let's meet some patients so we can put to work what we have learned about hepatitis E diagnostics. Our first patient is Hannah. She feels sick and had to vomit at home. She's feverish and her skin has a yellowish color. Her symptoms started 1 week ago. 4 weeks ago, she came back from Mexico when she visited family. Obviously, we think about hepatitis. Let's order lab tests. In Hannah's lab report, we can see that her liver enzyme function is significantly elevated. Furthermore, her hepatitis E tests are positive. Hepatitis E RNA is also detectable. So what's your diagnosis? Hannah has no history of immunosuppression. So let's take a look back at the graphic dealing with immunocompetent patients. Her ALT is very high, which signifies serious liver damage. Anti-HEV IgM and IgG are both positive, and we could detect RNA in Hannah's stool. Based on these results, we can conclude that Hannah is most likely in the early phase after infection. So Hannah is suffering from an acute hepatitis E infection. Let's see our next patient. Our second patient is Pete. He suffers from abdominal pain of recent onset. In the lab report, we can already see elevated liver enzymes. Pete received a lung transplant 8 years ago. Currently, he is on immunosuppressive therapy. Furthermore, he tells us that he's a passionate hunter. Based on Pete's history, we include hepatitis E screening in our lab report. We can see that his liver enzyme function is significantly elevated. His anti-HEV antibodies are negative. However, the lab detected HEV RNA in Pete's stool. What does that mean? Since we know that Pete is taking immunosuppressive medication, we should consider this in interpreting his lab results. We know that immunocompromised patients can have problems producing antibodies to the virus. So in Pete's case, it is essential to measure RNA. His lab report shows elevated ALT levels as a sign of liver damage, but negative antibody tests. However, there is RNA detectable in his stool. Pete is suffering from an active, ongoing HEV infection. Based on the laboratory findings, we cannot determine when Pete was infected. It may have been recently or more than 6 months ago. However, it is not important to know that. What is important is that Pete gets appropriate treatment and follow-ups. Congratulations! Now you can handle hepatitis E lab results.
So I hope you liked this video. Absolutely make sure to check out the course this video was taken from and to register for a free trial account which will give you access to selected chapters of the course. If you want to learn how MedMastery can help you become a great clinician, make sure to watch
Application in medicine. The hepatitis E virus transmitted mainly through the fecal oral route due to fecal contamination of drinking water. This route accounts for a very large proportion of clinical cases with this disease. The risk factors of hepatitis E are related to poor sanation, allowing virus excreting in the face of infected people to risk the drinking water supplies.
Hepatitis E is RNA virus. Spread by the fecal-oral route. Incubation period 3 to 8 weeks. Common in Central and Southeast Asia, North and West Africa, and in Mexico. Causes a similar disease to hepatitis A, but carries a significant mortality, about 20% during pregnancy. In general, hepatitis E is a self-limiting viral infection followed by recovery. Prolonged viremia or fecal shedding are unusual. In acute infection, IgM antibodies to hepatitis E virus are positive. Does not usually cause chronic disease. A vaccine is currently in development, but is not yet in widespread use. Thank you for watching. For more videos, subscribe to our channel.
Pros and cons. In rare case, acute hepatitis E can be severe and result in fulminant hepatitis, acute liver failure. These patients are at risk of death. Fulminant hepatitis occurs more frequently when hepatitis E occurs during pregnancy. Issue applied in Ecuador. Every year there are an estimated worldwide, leading an estimated 3.3 million symptomatic cases of hepatitis E. In conclusion, Ribavirin as monotherapy may be effective in treating chronic HIV infection. 3-month course seems to be an appropriate duration for this therapy, so a longer therapy can be given to heavily immunosuppressive patients and those who still have viremia 1 month after the initiation of therapy.